Regarding the septic arthritis of the hip, less than 2 years, it is group B streptococci. More than 2 years, it is Staph aureus. In 4 to 6 years of age, there is a predilection for H. influenzae, and the older age, gonorrhea is as STD is possible. A Cocker criteria was developed, which states non-weight bearing, fever of 38.5, ESR of more than 40, and WBC count of more than 12. If all the factors are involved, 99.5% it is septic arthritis. If 3 factors are involved, 95% risk of septic arthritis. If 2 are involved, 40% risk of septic arthritis. And 1 is involved, then less than 3% risk of septic arthritis. Luckman has showed that CRP and non-weight bearing are the 2 important factors. Moreover, Singhal has shown that CRP of more than 20 is the most important indicator instead of the 4 Cocker's criteria. When I see a patient, the patient would be unwell, can have fever, can be in a position of comfort, that is flexed and abducted hip or flexed knee. There will be tenderness around the joint line. Active range of motion would be obliterated and would be avoiding. The patient might have fever and constitutional symptoms of weight loss and inability to eat. Anyhow, the patient would need to be investigated in the form of, if the fever is there, I will do a blood cultures, do certain lab investigations, that is full blood count, CRP, ESR, and WBC count. I would like to do a hip aspiration before going for operative intervention itself. Ultrasound is a dynamic and operator dependent, but it is possible to do a musculoskeletal ultrasound to exclude any effusion of the hip joint. Anyhow, MRI is one which can identify fluid inside the joint itself. If I have a child of a hip septic arthritis with the high suspicion of septic arthritis, I plan to operate the patient. My operative plan would be a Smith-Peterson approach, an interior incision between the sartorius and the tensor fascia lata, and then rectus femoris and gluteus medius. Identify the hip joint. At that position, I will try to aspirate the hip first before opening an incision, because I want to have a clear specimen of the fluid. I will take that fluid and do lab investigations, which will consist of gram stain, WBC count, culture, cell analysis to find the neutrophil counts. I will do a washout of the hip joint, taking care of the posterior inferior aspect of the femoral neck region, which needs a thorough washout. After that, I would not place a drain itself. I prefer not to close the capsule because there is here more predilection of increased pressure in the hip joint causing AVN. I will close the wound. I will start antibiotics, which is empirical at that moment. Discuss the patient as an MDT approach with microbiologist, which will guide antibiotic treatment, which I will change after the results have arrived. Anyhow, the patient would need 2 weeks of antibiotics IV and 4 weeks of antibiotics oral. I prefer to do a serial CRP to identify that the CRP count is reducing and the patient clinical markers are also improving.